Hi everybody, it's Raj Mago from simpleandpractical.com, and it's a real honor for me to be interviewing today Professor Katharine Phillips from Weill Cornell Medical College in New York. Thank you so much, Dr. Phillips, for speaking to us today.
Oh, you're so welcome. I'm delighted to be here. Thank you.
Uh, Dr. Phillips, for those of you whom who may not know, is internationally recognized as a leading expert. I mean, she is the leading expert on body dysmorphic disorder and one of the leading experts on obsessive compulsive and related disorders. She was chair of the DSM workforce on anxiety, obsessive compulsive, PTSD, and so on for many years. Her bio is just amazingly impressive. I'm personally honored that she is on the editorial board of Simple and Practical Mental Health. So I'll put a link to her bio and her incredible credentials. So Dr. Phillips, I will jump right in to asking some of the questions that our readers sent in and requested to ask you. So in terms of the treatment of OCD, would you agree SSRIs are usually the first line, not necessarily because they are more effective than clomipramine, let's say, or others, but because they are better tolerated? And one of our readers asked, like, what about like among the 6 SSRIs? Like, how do you choose between the 6 SSRIs? Is any one of them better than the others in treating OCD?
That's a great question, right? The first line treatments for OCD are either an SRI or cognitive behavioral therapy that's specifically tailored to OCD.
Yeah.
Typically, exposure and response prevention is the core piece of the cognitive behavioral therapy.
Right.
Among the 6 SSRIs, they have all been demonstrated to be similarly effective. Of course, one may be more effective for one patient than another, but you can't predict that ahead of time.
Yeah.
So I think they are all good options. There's been some thinking or some perhaps perception over the years that maybe fluvoxamine is more effective than the other SSRIs, but that's not the case.
Right.
It's
a common misconception. It's a common misconception that fluvoxamine is more effective. There's no basis for that. It's just an artifact, I guess, of the FDA indication.
Yeah.
Because it has an FDA indication for OCD.
Perhaps, and I think the company that first marketed fluvoxamine was very interested in OCD and actually did a lot to advance recognition and treatment of OCD. And so that may have something to do with it as well. And perhaps that, yeah. So I think that, other SSRIs are indicated for OCD as well, right, by the FDA. So sertraline, fluoxetine, paroxetine. So in addition to fluvoxamine. So I would choose based on potential side effect profile. Certainly you want to look at the past trials that the patient had. Right. If they've had some good trials and they did well with one of them, you may want to use that one again. Yeah. If they had a decent trial, which is not so common, and didn't do well, you wouldn't want to use it again. I often will start with fluoxetine, sertraline, or escitalopram. Although with escitalopram, you often, almost always have to exceed the FDA maximum dose. And so that sometimes is problematic in terms of insurance reimbursement for the patient. But I think all the SSRIs are equivalently effective. I think paroxetine tends to have more side effects and more likely to have discontinuation symptoms if you end up stopping it. I do not use citalopram anymore because with that newer FDA dosing limit of 40 milligrams a day, which I think is firmer than for the other SSRIs, just my impression.
Yes.
We often need higher doses than 40 milligrams a day for OCD. So I don't use citalopram anymore. And unfortunately, escitalopram does not have such a firm limit and is very similar. So that's a very good alternative.
Right. So that's a very important point that we should, even when we are starting a new patient, we should, because we know that many patients will end up needing high doses, we have to think ahead. Because if you start, I've made this mistake in the past where I started somebody on a medication and then later realized that, they need to go to a higher than usual dose and now you have to change. That would be a very strange situation. So don't want to make that mistake. we have to think ahead. So I also, like you, don't prescribe citalopram because of that same reason.
Yeah, that firmer dosing limit
compared
from
to
the
that.
FDA.
And even with escitalopram, even though it doesn't have a warning in the United States, but it does have a warning in the European Union. And I think my understanding is that the reason that escitalopram doesn't have a QTC prolongation warning is that in the study that the FDA mandated, 30 milligrams at 30 milligrams there was QTC prolongation compared to moxifloxacin, but because 30 milligrams is not an FDA approved dose, so they couldn't put a warning. Yeah. They couldn't put a warning. It's a technicality.
Yeah. I've used lots of escitalopram over the years, as you probably have. I not uncommonly go up to 40, 50, 60 milligrams a day.
Yeah.
I feel that FDA maximum dose for the escitalopram is relatively low compared to the other SSRIs.
Right.
And I do check an EKG at 40 and above.
Right.
And I've never seen a problem. I mean, there is a question about how clinically significant that, QT prolongation really is. I tend to err on the side of safety, and I do check at 40 milligrams a day. And if I go up a little higher, I'll recheck. I've never seen a problem, actually.
Great.
With QT prolongation.
So citalopram, would be one to try to avoid only because of this reason. Yeah. Other 5 are reasonable. And, several, there's more than one option. So this is a good segue into the related question, which is that we know that, as you said, that higher than usual doses are frequently needed for OCD. So how many weeks would you try? So supposing we have somebody on sertraline, let's say 200 milligrams.
Yeah.
How many weeks would you try them before you would consider going above the usual top dose of 200 milligram?
Yeah. So when you say higher than usual doses are needed, we're talking about relative to depression.
Yes.
And higher than the FDA maximum.
Yes.
Which again is an option, I think, for all except citalopram and clomipramine because of that low therapeutic index and the risk of seizures or cardiac side effects. So, I started the usual starting doses for all these medications, 20 a day for fluoxetine, 10 for escitalopram, and I gradually raised the dose. I try to get up to the FDA maximum or 30 for escitalopram, because again, I think that FDA max is quite low for that specific medication. Yeah. I'll try to do that within a couple of months, assuming it's being tolerated. And assuming that I'm not seeing much in the way of improvement. Now, if I see a patient starting to get a lot better on 40 of fluoxetine, I may stay there for a while and just give it more time. For example, if they're starting to get better at 4 weeks on 40, I don't necessarily keep going up at that point. And, that's the art, as we all know. Yeah. Prescribing, just as we would do for depression or anything else.
Yes.
But I'll often get up to the FDA maximum, again, 30 for escitalopram after a couple of months. With sicker patients, I might titrate even a little bit more quickly. And with patients who are having side effects more slowly, we always individualize that, of course. And then I might keep them there for another month or so. And we like a good 3-month trial. For OCD minimum. And then I think if I'm not seeing a really good response and they're tolerating the maximum FDA dose well, I will start to gradually increase that dose further over the FDA maximum. And I think maybe the most important thing I want to emphasize today is for clinicians to be aware of the maximum SSRI or SRI doses in the American Psychiatric Association practice guidelines. The APA practice guidelines lay out the maximum doses that are sometimes needed for OCD, and they are much higher than I typically see clinicians using. Right. So when I see patients for consultations or new patients, almost none of them have reached those kinds of doses. And I find that they're often very well tolerated, and that side effects often get better with time. Yeah. So I'm happy to give those maximum doses if you'd like.
Yes, please. Yes, please. There was actually that's anticipating a question that I was going to ask. That when we say that be open to going above the a maximum dose that we use for major depressive disorder,
Yeah.
but there must be some limit that we usually would not exceed. So if the APA practice guidelines list a certain dose, that's a really good and reassuring for us that that is not a ridiculously high dose.
I agree. And these medications, the SSRIs, though, have a high therapeutic index. You probably can't go higher, but I occasionally do. But I think the fact that these doses are kind of codified in the APA practice guidelines is reassuring to me, right? So when I go up to those doses. So fluoxetine 120 milligrams a day.
Fluoxetine 120 milligram per day, okay.
Fluvoxamine 450.
Fluvoxamine 450, okay.
Sertraline 400.
400, so these are significantly more than the MDD doses, okay.
Double. That would double, right?
That's double,
Paroxetine 100.
Yeah, okay.
Escitalopram 60.
Okay.
That's triple the FDA
triple
maximum,
the FDA
right?
dose, yeah.
Whereas with fluoxetine, it's only 50% higher.
Yeah. Instead of 80, it's 120. Yeah.
Yeah. And I often go up to these doses if I need to.
Yeah.
And I often get much better treatment, much better responsive symptoms.
100%. I've done this over and over again also. And so which one did we leave out some?
Clomipramine, I stick with 250. I don't exceed that maximum FDA dose because of that lower therapeutic index. Yeah. And citalopram, I don't use anymore because I think that 40 milligram max is pretty firm. Yeah. And it's often too low for OCD patients. So I also just want to mention a wonderful study that I'm sure you know of because you're so knowledgeable about everything, but a study that was done with sertraline, patients with OCD. Phil Nyan was the first author. Yeah. And they took a good size sample of patients with OCD who had not responded to 16 weeks of sertraline up to 200 milligrams a day. Yeah. At 200. And then they asked, how will patients do better if we randomly assign them to 400, going up to titration up to 400 a day versus staying on 200 a day. So they randomized those patients on 200 a day to continue on 200 or titrate up to 400. And the group that titrated up to 400 did better. Yeah. The mean dose was 357 milligrams a day of sertraline. Yeah. They did better than the group that stayed on 200 per day. And what was really nice is the adverse events were no worse in the group that went up to the higher dose. Yeah. Yeah. So I think this is also a very nice study that kind of substantiates those higher doses in the practice guidelines and should make us feel pretty comfortable with using higher doses. Again, as long as the patient's tolerating the medication well enough, and often they do. Right.
Right. So so you've made so many good points, which I want to make sure I'm summarizing and understanding them correctly. So that the idea of using high doses, higher than usual doses, is supported by the APA practice guidelines. It's also supported by a randomized, double-blind, controlled clinical trial, the Nyan et al. I think that's the only paper that I know that's a randomized double-blind study. We have reviewed that on Simple and Practical before in our article about high-dose SSRIs, and I show it to patients. And an extensive clinical experience supports this idea. So therefore, it's very unfortunate. Would you agree that we see patients with OCD who are not treated on higher doses? Right. All the time. And that's very unfortunate, and they are continuing to have symptoms. So this is a major problem.
Yes, and another major problem, of course, which all clinicians are aware of, but just to highlight it, is the problem of poor medication adherence, which is rampant, and not just among patients with OCD, but that's always something that we have to be attending to and ask the patient, about adherence. And I often say I try to normalize it a bit and say sometimes, it can be difficult to remember to take the medication every day. How are you doing with that? And do you find that sometimes you're forgetting it? Because that, of course, can prevent a good response. And we all know that, but just to remind people that the non-adherence is such a problem across all diagnoses.
All diagnoses, and
so often simply taking the medicine every day just converts non-response into response. So
Right, right. But also, and then the other third point that also, if I could just emphasize what you already said, which is that the trials for OCD, the trial of SSRI needs to be longer than
yes,
for
yes,
major depressive disorder. So a
yes.
6 to 8 week trial is not adequate for OCD. Roughly three
No,
months as a kind of like a
yeah. I mean,
as a
some
rough
people,
guide. Yeah, of course, we have to individualize, but as a rough guide, it would be about 12 weeks would be considered
yeah,
a reasonable trial, right?
yes. And some people, of course, start to improve in 4 to 8 weeks, but
Yeah,
you don't stop the trial at that point. So
we
you want
should.
to go out 3 months.
Great, great.